But I'm Dr. Skutzine. I'm a pediatrician and director of the Child and Family Health Institute. So welcome everybody. As you join, please introduce yourself in the chat. I do want everybody to know that we are recording this session to share through our CFHI website. Let's see, other housekeeping items. So the mission of the Child and Family Health Institute is to foster interprofessional and transdisciplinary collaboration, both within and within ETSU and between ETSU and the region in particular around child and family health, quite broadly in terms of research, service, program development, advocacy, as well as research. The CFHI is looking for new members as well as new steering committee members. So if you think that might be of interest to you, you can find information about membership as well as how to apply through the ETSU Child and Family Health Institute website. And applying is pretty easy. You just have to submit your interest with a CV. The other thing I wanted to mention is that you will receive an email with a link to a feedback survey following this session. And so that's just to help us improve our collaborative series and maintain it. And as part of that, you'll be able to suggest future topics and speakers. So welcome everybody. I have the pleasure of introducing Dr. Joyce Troxler, who is our speaker today. Throughout our time together, feel free to enter questions or comments in the chat as they occur to you. We do try to reserve at least the end of our time together for some discussion, but we want this to be as interactive as possible. So I'll be monitoring the chat. Dr. Joyce Troxler is board certified in family medicine and addiction medicine. She was raised in rural central Appalachia, is a former National Health Service Corps recipient, and is a graduate of the Quillen College of Medicine. She completed residency training in Asheville, North Carolina, and went on to practice in a rural community in Southwest New Mexico. And in recent years, that practice became largely focused on providing treatment for substance use disorder. As I mentioned, she went on to become boarded in addiction medicine. Fortunately for us, in 2018, she returned to Tennessee to join the Department of Family Medicine as an associate professor at ETSU. In this role, among many things, she led the formation of an ACGME accredited addiction medicine fellowship that started in 2019, and she serves as the program director. The ADM fellowship graduates 2 physicians per year. She's also currently and has for many years served as vice chair of the Rural Health Member Interest Group of the American Academy of Family Physicians. So she is going to be speaking with us today about relapse prevention. But I noticed, Joyce, on your title slide, that you reframed that as facilitating maintenance. So I like that reframing, and I wanted to mention that. So I'll let you get started, and thanks again.
Do I need to share my screen again, or are you guys all seeing it? Reshare?
Yes, reshare. Katie, stop sharing that title slide. If anyone's just joining us, one final reminder, feel free to introduce yourself in the chat.
You're seeing the slideshow now?
Yes, we are.
Okay, perfect. All right. It's going to look like I'm not looking at any of you because I'm looking at my slides, unless I can make it pull up here. Hang on. I might be able to do that. Oh, I can. Okay, here we go. Now it's going to look like I'm looking at you. All right, facilitating maintenance. As Dr. Skutzine mentioned, I did change the wording. Relapse prevention is, relapse is one of those things, one of those words in addiction medicine that is losing favor. We keep changing our words and our acronyms. So this is one of them, and we're going to talk about that a little bit as well. So facilitating maintenance. Objectives today, challenging our perceptions. What is the actual definition of substance use disorder? Looking at stigma and biases associated with the diagnosis and the treatment, understanding the concept of recovery drift, and then supporting our patients in recovery. All of these things go into facilitating recovery of our patients. So just a question to ask yourself. You don't have to put this in the chat. You don't have to unmute and answer the question. But do you know anyone who uses drugs? Let you ponder for a few seconds. I have a funny feeling nobody's thinking no right now. But part of that challenge is, what about you? And I don't mean like, oh yeah, she just figured me out. I'm a total, hardcore heroin user. I'm outed now. It's not what I'm talking about. It's more of, what substances do we all find that we lean on in our lives when we're having a hard time, when we are feeling challenged or low or down, or we want to feel something different, or we need a pick-me-up. The desk, the standing table we have in the middle of our shared office in our clinic, there is kind of a crazy mess of a variety of chocolate in the middle of that table. And yes, I got called out yesterday morning because by 10 o'clock I was already in the chocolate. So we all have the things that we go to that we will lean on. And so thinking of ourselves as different because, well, it's a piece of chocolate or it's a Coca-Cola. How is that different than what some of our patients experience in that urge, that drive, that inability to change behaviors? Because there are some other substances and behaviors and activities that maybe we also engage in that could get a little more dangerous. Thinking about substance use disorder as only substances that we put in our bodies versus activities that cause the release of certain substances in our bodies. That sense of, I'm going to work hard, I'm going to work long, I'm going to be the best employee ever, never mind my family never sees me, and I have so many screens, it's ridiculous, I can't keep up with them all. Or working out to the point that, I don't know, your BMI, your body mass index is 15 because you've got a body dysmorphic disorder. So even behaviors can be wrapped into when we think about substance use disorder, because it's about the behavior that leads us to want to put a substance into our system to feel different, and knowing that the end game is feeling different. So it's not just substances we can put in our body, alcohol, nicotine, but activities, sex, that make us feel certain things that we want to feel and experience again and again. And certainly replacing those feelings of, I'm not enough, I'm a bad person, I'm a bad mother, I'm a bad whatever, I'm not worth X, Y, or Z. And therefore I engage in other activities to replace and cause other feelings that I can handle, and maybe I want those feelings instead of. So thinking about, again, this is that challenging perceptions. What are we doing? Is it healthy for us? Is it healthy for our community? And also thinking about substance use disorder a little bit differently as well. And it's not just those individuals who use heroin or use Roxys or use methamphetamines or fill in the blank, drink 4 high gravity beers in a single sitting, which is actually 2 standard drinks per high gravity beer. But thinking about it a little bit differently, and also backing up a little bit and thinking about just how does substance use disorder fit into a bigger picture of individuals who have health conditions. So for instance, you have a woman, 32 years old, comes into your office. She just moved from Kansas. She was getting routine regular care at a clinic in Kansas. She's come to your clinic to establish as a new patient. She does have some chronic medical conditions. She's started having issues with her medical problem at about age 18, and there is positive family history on the paternal side. She does take medication daily. She takes it as prescribed, as she tells you, and you perform some preliminary screening labs in your clinic today, and those labs confirm medication adherence. This is an opportunity, if you guys want to unmute and tell me a little bit about what you think her condition might be. What medical condition might we be describing here? Or you don't have to unmute. I can just go on to the next slide too.
Any thoughts on this, this patient?
Could she be diabetic?
She could 100% be diabetic. Her dad has diabetes. Her paternal grandmother has diabetes. She has cousins who have diabetes, and she takes metformin, 500 milligrams, 2 times a day. She has hemoglobin A1C. You have a point of care hemoglobin A1C you checked in your clinic today, and her hemoglobin A1C is 7.2. She could totally have diabetes. She could have hypercholesterolemia, and you checked a lipid panel. She could also have opioid use disorder, and you did a point of care, and it came back showing positive for buprenorphine, because that's the medicine she was prescribed in Kansas, and she's hoping to have re-prescribed here in your clinic. And when you sent off her toxicology for confirmation, it comes back showing that, yes, indeed, the buprenorphine parent drug and metabolite norbuprenorphine are both present, indicating that she has been taking her medication as prescribed, and there are no other substances present. So chronic medical condition, that could be so many different things, especially when we start thinking about substance use disorder as a chronic medical condition. So chronic disease, structural and chemical changes in the body. We all know diabetes definitely has structural and chemical changes in the body, kidney issues, vision issues, behavior, genetics, and environment all play a part in our chronic medical conditions, just like it does in substance use disorder. Medication can and is often part of a treatment plan, and control of the disease is the goal, not a cure. So DSM-5 gives us a lovely definition: chronic relapsing brain disease characterized by compulsive drug-seeking use despite harmful consequences. There are 4 C's in addiction or substance use when we think about just kind of boiling down the DSM-5. I guess they kind of boiled it up and they made it into this really lovely checklist of things to think about. But compulsion and craving, so you feel a compulsion, a push, a need to use a substance. You find yourself thinking about it, wanting to use it, that craving that you can't get away from. And then even though you know the consequences are not going to be good if you use, and you have no control about whether you use or you don't use, it's a lack of control. So cravings and compulsions that, despite negative consequences, you have a loss of control over your choices and you continue to use. Those are kind of the boiled down, what does substance use disorder look like? Another way to look at it and think about it is someone going about their normal daily lives. They encounter a substance and it makes them feel really, really good. And then the substance wears off and they go back to their normal daily lives. Yet I liked what I felt. I want to feel that again. I use again, and again I get the euphoria. So that acute, occasional, every few days, maybe on weekends, it's a birthday party, turns into every day, multiple days in a row. Then we start rolling into the chronic use, and we start seeing things like tolerance and physical dependence, so that when we don't have the substance, unlike before, we just went back to our normal selves, we feel horrible. We have withdrawal symptoms, we're miserable, we have no energy, no motivation other than trying to get back to normal, and thus seeking substance, using again, just so we can get that normal feeling. And if someone does happen to find themselves in a situation where they can, will, and are able to engage with a provider who can help them with some type of medication, and medication-assisted therapy usually gets like, oh, that's buprenorphine or methadone. There's so many different types of medication-assisted therapy, and that is also a challenge I would have for everyone, is just thinking about treatment as treatment, and it can be so many different things. It doesn't have to be buprenorphine. It doesn't have to be methadone or naltrexone. Naltrexone is great in alcohol use disorder too, so it has a purpose, not just in opioid use disorder. When we're working with patients who have substance use disorder, we are helping them find their way to the recovery that they have defined that they want. And that may require medication, it may not. The medication we use may be Wellbutrin. It's hard to say. Just like in the patient that we could have been describing with diabetes, it was metformin, or maybe it was glyburide, or maybe they're on insulin, or maybe it's a combination of all of those. But they are using medications to help control the disease. And sometimes through lifestyle changes, someone can come off of those medications and not need them, just like our diabetic patient that we help with lifestyle changes, and they've lost 75 pounds and they're eating well and they're active and they aren't on medications anymore, but they are mindful of their condition and that they don't need to go eat cake all weekend long and wash it down with the Coca-Cola. The main player in all of this is our friend, the neurotransmitter dopamine. There are other neurotransmitters that are at play, but do not worry, we are not about to have a neuroanatomy or neurobiology or any type of neuro review here. We're just going to focus in on dopamine. Dopamine is the fellow that triggers the reward system in our brain. So when good things happen to us, we get a dopamine hit off of it. We feel good. We want to do that again. We want to repeat that activity, whatever it may be. For someone who is using substances, just as a pictorial guide of what that may feel like, you look at these different shaped bubbles, just your normal average, nothing really happening. That smallest little blue circle down there on the left side, that's kind of our base dopamine levels. You have the best day ever. Like, you get to go to the fair and you ride on all the roller coasters and none of them break, and you just have the best day ever. It's just dopamine all the time. You eat cotton candy and we're hitting all those lovely dopamine receptors that are connected to glucose. Best day ever. It's sort of like using some THC. You get some dopamine release with that. You get even more dopamine release with the use of heroin, and even more with methamphetamine. That desire, that need, that call, that compulsion to feel something different than what you currently are feeling. For many people with substance use disorder, they know how to get there, and so they will go back and use again because they're in a place where they don't have another answer. They don't have something else to help pull them out of the place that they found themselves, and they'll either continue use or, after a period of remission, return to use, which is kind of a visual image of what it might be like to have, regular amounts of dopamine versus, I just use methamphetamine and I think my head may explode. I'm so happy. One of the things that happens, though, with continued substance use is the dopamine starts to be depleted. There are those that can be born with the dopamine deficiency. Or this can occur because of repeated substance use, where we're just squeezing, like you're taking that sponge of your brain and squeezing all the dopamine you possibly can out. So if you have a wet sponge and you squeeze it the first time, like, you could fill a cup with all that water, but you keep squeezing that same little sponge and it's like you get a drip out and you're squeezing so hard your knuckles are white. Brain's kind of the same way. With that huge release of dopamine that it's been experiencing, it starts telling itself, like, we need to downregulate some of the stuff that's happening in here. We don't need to be making as much dopamine. We don't need to be making as many receptors to receive all the dopamine that's floating around in here. Like, we need to bring this back down to normal. Our bodies really like homeostasis. The occasional, like, "Whoa, that was fun. Okay, let's settle down a bit." Kind of gets hijacked when substances are continually going into the system and pushing out ever increasing amounts of dopamine to the point that we just don't have as much. And therefore, people find that they need more substances more often, and quite honestly, a variety of substances to achieve some of that same dopamine, even just to get back to normal, which takes us back to that graph you guys saw a second ago with those lovely squiggly lines all over it. People find themselves in a place where they're using just to get to normal. And that's part of that downregulation of the dopamine neurotransmitter and the receptors for dopamine itself. So dopamine deficiency, lack of motivation, fatigue, apathy, trouble concentrating, behaviors that leads to the stigmatization of this disease. Like, they don't want to do anything. They have no motivation. They're not interested in change. That's where the craving comes from, that lack of dopamine, needing to fill back up, doing whatever you can to get what you need to make the dopamine release again, and then engaging in primal actions to survive, to satisfy the craving, to put the dopamine back in the system. People will find themselves doing things that they never thought they would even think about, much less execute. It is a definite, you'll hear people talk about it as a hijacking of the brain. Things get rewired. And that's part of recovery, is working on the rewiring of the rewiring and finding your way back to base levels of dopamine that make you feel normal, that you can find happiness, that you can find other ways of managing and coping that don't require return to use or continued use. So knowing that a number of our patients have experienced difficult past, sort of the patient, if we go back to her, our 32-year-old, if we want to say that her chronic medical condition was opioid use disorder, and she started off by pinching her dad's oxycodones and using them, and then she started snorting them, and he was getting more and more than he should have, and maybe mom was in jail and it was just dad, and she was not in a well-balanced home where he was using substances. She started using them at 18 because they weren't hers, and then she escalated her use. The thought that those can be walking this world immersed in suffering and not be touched by that suffering is as unrealistic as expecting to be able to walk through water and not get wet. So that's my little picture and quote there. But the lives that our patients lead, the things that they find themselves in the middle of just because they were a child born into a family that has difficulties. So some of that genetics and environment that I referred to on the slide before, this kind of gets back to our ACEs, adverse childhood events, and knowing that the more ACEs a child encounters, experiences, increases the likelihood that they may indeed develop a substance use disorder, increasing the likelihood that that substance use disorder will also include utilizing syringes and injecting substances, increases the more that your ACE number goes up. Adverse childhood experiences includes things such as a parent going to jail, parents being divorced, someone in your family having a substance use disorder, someone in your family having a mental health condition, someone in the family, like in your home, having committed suicide, inappropriate touch by someone in the family or someone older than you. There are a number of things. I didn't include a slide on ACEs, but just if you aren't aware of what they are, which I imagine most people on this call are, you can just Google ACEs, ACEs, and you can find them. But thinking about the suffering and loss that our patients experience who have substance use disorder and somehow expecting them to walk out of that unscathed is unrealistic. And us as providers in providing care for patients who have been at the hands of suffer and loss, and the transference of hearing their stories and taking them in, thinking that we can walk by them through this water that they have been mucking about in, and thinking that we're not going to get wet as a process is also unrealistic. So thinking about ourselves and taking care of ourselves in the process of caring for our patients is also incredibly important. And one of the ways in which we can help take care of our patients, help be more human with ourselves as well as our patients, is thinking about the words that we use when we interact with our patients. And that's why word choice matters. Things like dirty, clean, relapse, and addict, alcoholic, those are the words that are on the outside. We're going away with them. That's why instead of, I can't remember what we said it was before, but something about the title of the slide before, the introductory slide before I shared my slides was about relapse, preventing relapse. It's really about facilitating recovery. And instead of relapse, we talk about return to use. So if someone has walked the walk of recovery and they've been doing really well and they have a return to use, it's a return to use. It's a learning opportunity. It's not a relapse. It's not you did something and now you have a dirty urine sample and you're just an addict. Like that's not the message that we want to send to our patients. They may use those words and think that way about themselves, but it is not something that we can repeat those words and just reinforce like, yep, you're right. That's exactly what it is. One way just to kind of pull it out of, some of this language and how comfortable or uncomfortable we may feel with it. I like to point out the fact that I'm from this region. My parents are from Southwest Virginia. and I grew up in Northeast Tennessee, so I'm a hillbilly. And I'm proud of my hillbilliness, but I can call myself that. I know somebody from Kansas, say this patient who just transferred us, and she's like, oh, you're one of those hillbilly doctors. I might take offense. So I might use words to describe myself. I'm not going to let somebody else use to describe me. So same thing with our patients. We may hear them refer to like, doc, I peed dirty for you today. I'm not going to say those words back to them. What I might use actually is appropriate. So when my patient tells me that they've used methamphetamines, I'm not going to say that I have an unexpected result or an inappropriate result. I actually have an appropriate result because it's positive for methamphetamines, and they told me that. So it's appropriate for the history that I collected. So perspectives of what's happening with our patients, using words that help our patients feel better about themselves. And not engaging in words that are stigmatizing. So word choice definitely matters. Stigma, people with substance use disorders are often viewed more negatively than people with physical or psychiatric disabilities. It oftentimes can come across that we're thinking that an individual with substance use disorder has made a choice. This is the choice they've made. If they were stronger, if they had more willpower, if they were a better person, they wouldn't be doing this. And quite the opposite is true. Utilizing the term abuse, it's another one that is hard to get out of our lexicon. And it's actually in the name of some of our national entities, National Institute of Drug Abuse, NIDA for one. So it's woven into our language, but trying to move away from it as best as we can, because abuse is associated with negative judgments and punishment. When the truth of it is we can use adjectives that better describe what our patients are experiencing. Someone has disordered use of opioids. So opioid use disorder, right? You just get to play with your semantics and flip it around a little bit. Or someone has high risk use of alcohol. So just thinking about our word choice and the way in which, this is my litmus test. If I'm saying something about a patient and I turn around and like, oh, the patient's right behind me, how would I feel about them overhearing what I had to say? And so the language that I use in the room is the language I use out of the room. I don't want to catch myself saying something that I would feel embarrassed by my patient hearing me say it. So in the room and out of the room, the words that I use are supportive and positive. Sometimes I might be frustrated, but if I'm frustrated with what's happening with the patient, they need to know that so we can talk about it, because maybe my goal for the patient is not the patient's goal, and we need to align those goals and work together and not having either one of us feel frustrated. We also want to avoid stigmatizing language and attitudes because it's a dehumanization of the individual. Based on things that, quite honestly, depending on the society in which you live, they could change. I have a number of patients with ADHD, and there's a lot of stigma around that diagnosis as well. I used to work with a pediatrician who, in working with children with ADHD, would talk to them about it. Like, at one point in time in our society, ADHD was a really important quality to have, because when you're out in the hunting party and everybody's focused on the gazelle, you need somebody in the group going, hey guys, there's a lion back there. Hey guys, there's a lion back there. Because you're not just so hyper focused on the goal, you're paying attention to the whole environment. So recognizing that some of the things that we view as bad may have a lot to do with the society in which we currently live. So approaching people for the people that they are and not what they wish they could be. There's a lot of words on this slide. So replacement and substitution, I actually have a someone I look up to in the substance use disorder treatment world. She's a family medicine doc in rural northern New Mexico, and she's shared some of her slides. She's given national conferences for ASAM, American Society of Addiction Medicine. She's pretty well known in the addiction medicine circles, and I have some of her slide sets from several years ago that she refers to buprenorphine as opioid replacement therapy. Because, like I said, we used to use these words, and we're trying to move away from them because we recognize words do carry meaning, and it sort of gives people the feeling that, well, we're just substituting one addiction for another. We're just replacing heroin for buprenorphine, when that isn't the case. It's all about the behavior. So if someone is using buprenorphine in the same way that they use their heroin, then they have substituted one substance for another and their behavior hasn't changed. So when it comes to substance use disorder, we're working on behavior change, and not so much that we got rid of that drug because another one's going to show up. Because quite honestly, my patients on buprenorphine, they're using methamphetamine because we haven't gotten at the behavioral issues that feed the desire to continue to use. And I even did it myself. It's not a desire, it's a compulsion. So word change is important and paying attention to what you say, which gets us over now with that introduction to the return to use idea. What do we do when our patients do return to use, and recognizing that we don't want to use the term relapse? Although we do and we will, and it will sneak into our language, but trying to think about and be cognizant of our word choices. So again, just to kind of challenge our perceptions, what other chronic medical condition do require perfection and treatment? Our diabetic patient who's not always using their insulin, or using it the way that we prescribed it, or they quit taking the metformin, but they didn't tell us until 6 months after they quit taking it. And then medical conditions, do we use the term relapse? I was thinking about this a little bit because we do talk about substance use disorder as sometimes being in remission. It's actually an ICD-10 code that I could choose, opioid use disorder, severe, in remission, controlled environment. I can use remission as part of an ICD-10 code when I'm doing my documentation for a patient visit. And we talk about cancer as being a medical condition that can be in remission. But I don't really think people talk about cancer as, well, they went and relapsed on their cancer. So return to use, it's kind of the way that we want to start thinking about this, because it's not a failure. It's not, well, they relapsed and it's over, forget it, never mind. We can't do anything. It's a rule, not an exception. People return to use not infrequently, using it as an opportunity to learn and strengthen motivation for change. So we as clinicians and providers and caregivers in the world of substance use disorder can often see a return to use as a failure because somebody used again, because the patient I saw yesterday returned to alcohol use. He definitely sees it as a failure, but that's something that we're working on. Again, I'm not going to call it that to him because I don't see it that way, just as I don't see him as an alcoholic. I see him as someone who has alcohol use disorder, and we are working on learning new ways to manage feelings, emotions, situations in his life that he'd rather not. That when he feels overwhelmed, the way to manage it isn't drinking the high gravity beer. The way to manage it is call your mom, which he did this last time. That's new. That's different. He learned from his last return to use. I can reach out and ask for help. And he did. He still went on and drank the beer, but something new and different happened with this particular episode of return to use. And that's just it. It's an episode. It's an occurrence. His episode did last for 11 days, but the previous time it lasted 2 to 3 months. So again, that's a change. That is him moving along the continuum. This isn't what I want. His motivation for change is actually getting stronger, even though he's had a return to use. He's getting stronger in his desire not to do this again and again and again, because he has done it several times. But with each time, he learns more about himself, especially if he's in a supportive environment, to recognize this is an opportunity to learn. Let's talk about what led up to the return to use, what happened during the return to use, and now that you're sitting here in front of me, reflecting on that return to use. Some of the reasons why return to use happens, patient really wasn't in a maintenance stage. Like they may have been doing great, kind of the honeymoon period, like I haven't used, I'm feeling awesome, this is great, I'm keeping appointments, I'm doing fabulous. And then there was that person in the aisle at Walmart that I used to buy from. And next thing I knew, I was out by the garden section and they had some. And well, that's why I haven't seen you for the last 3 weeks. Because we hadn't prepared for the eventuality of running into a triggering event. Sometimes patients aren't aware of what their triggers are. And so actually having that opportunity to discuss the return to use and pulling it apart Well, I was bored. I was lonely. And again, I'm going to use the word that we're trying to not use, but it sounds a lot snappier this way. Autopsy of a relapse, because saying autopsy of a return to use is a little challenging, but autopsy of what happened, like what happened? I was feeling overwhelmed. The fellow who did have the return to alcohol use over this last week, he was feeling overwhelmed. He was lonely. He was by himself. Those are all things that he now recognizes as that is a dangerous combination for me. When I called my mom and she said, just come over. Next time, that's what I'm going to do. This time I didn't. So we're working on the preparation stage. When he hits those walls, recognizing this is my wall and I'm going to do this instead of. If we hadn't had return to use, we wouldn't have real life opportunity to discuss what happened and how do we want to approach it differently. Behavioral change is hard. Me not going into the shared office and just grabbing a piece of chocolate because I'm feeling frustrated, it's there. I know it's there. I'm going to go and do it. I could really work hard to not, and I can go through a period of weeks where I don't. And that's a tiny change. That's a tiny, tiny dopamine hit. You'll notice on that picture with the circles, there was no like, this is what it's like when you've had a piece of chocolate. Like it really doesn't do all that much to your base dopamine circle. So when you're using a substance like methamphetamine, that was a really big circle on that slide. And changing behavior is hard when you feel beat down. You feel that the world already sees you as someone who can't do this. All that stigmatizing language that we just went over, plus some really not so nice terms I didn't put on those slides. I have one patient, he's like, well, they all just see me as an addict, so I'm going to go be the best addict I possibly can be. And then he goes and he uses methamphetamine, the best he possibly can. So behavioral change is hard. And what we're asking of our patients is hard, and recognizing the work that they're doing. And even when they have fallen down, that they're trying to get back up, we get to be there to help cheer them on so they can get back up. And let's try this again. Because in the last week, even though when I went to the pharmacy to pick up my buprenorphine and they all look at me that way, and I just feel like they're all thinking of me that way, so I'm just going to go and be that way. It was one time that he used, and not every day between last visit and the next time he's seeing me. Motivation for change waxes and wanes. Some days feeling really good, really strong, I can do this. Other days, I'm tired. I don't think I can do this. And then this particular gentleman I'm talking about, someone who owes you money decides to pay you back in methamphetamine instead, and never mind that you're keeping your door locked, they leave it on the front seat of your car. So life happens. People will leave methamphetamine on the front seat of your car. So we need some new coping skills, and we find methamphetamine on the front seat of our car. So when I'm going to call my CPRS and tell her I have methamphetamine on the front seat of my car, what is her number? I lost her number. So some new coping skills, like let's make certain that number is saved in your phone so you can call and you can reach out. But because we know what happened, because we discussed the return to use, because our patient didn't feel like he had to hide that from us, that he can share that with us, we can talk about it, then we can go in and pull it apart and try to put it back together in a way that the next time a trigger happens, the next time someone leaves methamphetamine on the front seat, the next time someone feels overwhelmed, lonely, and is looking for someone to spend some time with, he finds a person and not a bottle of beer. We need to talk about it and come up with plans and options. I had one gentleman who he actually practiced in the mirror. We talked about it, and he went home and he practiced in the mirror because there was this one friend he just felt really uncomfortable. Like he admired this person. He was a good friend who happened to use and would occasionally bring stuff over. And he practiced in the mirror what he was going to say to this friend when he showed up again with substances. So helping your patients prepare for the eventual trigger opportunity. And if they do return to use, we're going to talk about the why and how that happened. So some of the reasons why, other than not being in the maintenance stage, or we haven't done a good job preparing, life happens, all that good stuff, there are things that we can do to help instill recovery. So healthy eating. I'm eating quality food. I'm getting nutrition. I'm engaging in fun activities, because my brain is learning that I can have dopamine releases from doing things like packing a picnic and going to the beauty spot in Unicoi County. I can get a hit off of that. I don't need methamphetamine to enjoy myself, and helping people relearn that you don't have to use substances to have fun or feel like you're a fun person, because it's not just about like, let's go have a wild party time. It's about feeling like I can actually do things. One gentleman we worked with, he would take a bunch of oxycodone just so he could go shopping at Walmart. And it's not because he had a bunch of pain, it's because he had some social phobias. And if he took a bunch of oxycodone, he felt more social. So you can actually go and do and be without having to put substances in your body in order to get that big dopamine hit. Like, you can go do a picnic at the beauty spot. You can go for a bike ride with your children or your significant other, or by yourself at Wing Deer Park. You can take a walk around your neighborhood. There's so many different fun activities. COVID has made that a little bit challenging, all the getting out and doing things, which that's a whole different lecture for a whole different day, and how pandemics have impacted our epidemic. Getting enough rest and exercise. Physical activity is so important for mental health and well-being. Going to meetings, whether that's going to an AA or an NA meeting, going to a Celebrate Recovery meeting, connecting to meetings online, because as I mentioned, that wonderful pandemic shut a lot of in-person things down. Even if it's just not a formal meeting, but a meeting of a group of friends, of peers, making certain that you keep those positive connections in your life. Going to therapy sessions, if you are still needing therapy, counseling sessions, that you're attending those and not scheduling and not going. Those are anchors for recovery. And when you start neglecting some of those anchors, they'll start dragging along the bottom a little bit, and your little HSS recovery there is going to start moving closer and closer towards return to use. So being mindful of what you're doing in your life, just as I mentioned with the diabetic, making lifestyle changes, and maybe the medications go away. As soon as they stop exercising, start eating unhealthy things, they're going to see things like blood sugars going up and a need to return to medication coming back again. In a way, you could look at that as diabetes recovery drift. Same thing with substance use. When we're not engaging in those activities that keep us anchored in recovery, we're going to find ourselves drifting back towards a return to use. So when, not if, your patient returns to use, normalizing, listening to your patient, assessing that sort of autopsy of the situation, intervening, recognizing that possibly there is an undiagnosed and non-managed underlying co-occurring condition, such as recognizing as you talk to your patient that they had a really hard time in school. They had a really hard time with attention. They had a really hard time passing their classes. They actually ended up getting a GED. They haven't been able to hold down a job because they're always scattered and unorganized. And despite the fact that you sit and talk with this person and think the person's really on their game, they just are not achieving at a level that their intelligence begets. Like they should be able to put A and B together a little more consistently. Maybe you have a patient who has ADHD that currently isn't being managed, and we need to change our therapeutic interventions to think more along how do we help someone with ADHD approach their life using planners. This is one of my new favorite terms, chunking tasks, where instead of like, I've got to clean this house, I'm going to pick up the trash. Well, your house may not be completely clean and all the toys put away, but the trash is put up, and that's progress. Maybe they do need a medication. So do they need to be on bupropion? Do we need to have, I can't say this one, so I'll say Strattera, even though I should say the generic brand. Do they need to be on a stimulant? Methylphenidate is actually, studies back this up. Methylphenidate is Ritalin, it's a stimulant, and that is the one that we should go to, number one, for persons with ADHD and substance use disorder. So the thought that I have a patient who has a stimulant use disorder who uses methamphetamine, and yes, I'm prescribing Ritalin, it's actually backed by evidence. And we'll see that the methamphetamine use starts to drop off because they were using methamphetamines to help treat their attention deficit disorder. Methylphenidate, Ritalin, is not an appropriate medication to treat stimulant use disorder, but when you have an underlying medical condition that is a first-line treatment for, you can use it in the setting of substance use disorder. And then making certain that you have follow-up for your patient who's had return to use, And it's not like, I'll see you in 4 weeks, hope nothing else happens. When you've had a patient who has returned to use, you want to see them in closer intervals. So number one, first, do no harm, but since we're human, we just might. Things to remember. We are not judge and jury. We are not the police. Our job as caregivers for those with substance use disorder is to assess and support, provide treatment options and guidance. So you may have been using a treatment option that's really not working for your patient. Be open to the fact that what you chose, you and your patient in a discussion, like, let's try buprenorphine. It didn't work out. There are other treatment options. They may need a higher level of care. It's our job to help them connect to what they need. And what they do with that is theirs. Be open to the realities of return to use and prepare our patients for that very real potential. One of the patients I was working with, she's like, I'm just not going to do it. I'm like, okay. And when you do, what are we going to do about it? It's like, I'm just not going to do it. So when she came back and she had done it, I'm like, okay, now can we have the conversation about what are we going to do when the methamphetamine presents itself again? And so we started having those conversations, because the reality is opportunity will present itself. What are we going to do with that opportunity when it does show up? Prepare our staff for when patients return to use. Sometimes it can be very disappointing in our staff and ourselves when we have patients who return to use. So just everybody recognizing this is normal, it does happen, and it's not the end of the world. And there are things that we can do to address when a return to use happens. Alternatives to the current treatment plan as compared to discharging from the practice. So if you have a patient who has returned to use or started using something like, okay, you're not using opioids and I have you on buprenorphine, but now you're using methamphetamines, that is not cause to discontinue treatment for your patient. You continue what's working because they're not using opioids. They're taking their buprenorphine, but they're also now pulling in another substance. So does that mean that we have some unaddressed underlying issues that need to be brought to light? And it may be that we need to change that treatment plan, that maybe buprenorphine isn't the right choice for this patient, or we actually have a depression, anxiety issue going on, some PTSD, and that's why we have return to use of a previous substance. Like 10 years ago, they had issues with methamphetamine, and now it's showing up again. Periodically checking in with patients. Those who left your practice because when you offered a different treatment plan, they weren't interested and they said, thanks, see ya, there's a clinic down the street I want to go to. Even calling and checking in with them and making certain that they're getting what they need. And even those who graduated out of your care, you've tapered them off of their medications, they're doing great. Just calling and checking in, wanting to know how they're doing, because we do care about our patients and how they're doing. And then keep the door open. That's part of that transitioning treatment plans, letting patients choose whether they want to stay in your practice or not, because this is the treatment plan that I have for you. But if they threaten bodily harm, you don't have to keep the door open in that case. I smile because we had one of our patients who left a phone message that maybe he was going to come down and kick a certain part of our body. And we're like, you know what? For you, the door has to be closed because we're not going to endanger ourselves or our staff. That rarely happens. This guy happens to actually do a lot of cocaine, and I think he has some anger issues, probably fueled by the cocaine, which is why he said what he said. However, he said the wrong thing, even though I wish we could help him with his return to use of cocaine and his anger. You don't get to threaten us. But the idea is keep the door open, offer alternatives, recognize that we're not here to judge our patients. We're here to assess and provide the appropriate level of care. So, lovely little poem, teeny weeny poem, because return to use, it's kind of like the barn burned down. But now that that happened, we can see the moon. Part of why I love my job is it's a collaborative sport. There are a lot of people who work really well together in my clinic. We have a lot of different backgrounds that we bring, but I also have many friends out in the world of substance use disorder treatment and addiction medicine. And I pulled a lot of what you guys saw today from all my friends out in the world of addiction medicine. And then there are some specific references for information that I pulled in today's presentation. And that is all.
Thank you so much for that presentation. And we have about 6 minutes left, so we love to open it now for questions or comments. Feel free to turn your camera on if your environment allows you to do that, unmute yourself, or you can also use the chat. And I appreciate all the comments about language that we use. I often find myself getting anxious, more not when I'm talking to patients, but when I'm writing about this topic or trying to communicate with other professionals to think, what word, am I using the right words? You know, but I think even more so, just the sensitivity and the way we frame it with patients, of course, but also with colleagues is so important. So I appreciated that.
Thank you.
Anybody have questions or comments for Dr. Troxler in the group? So Teresa Cannon said she wishes that she had the opportunity to hear this a year or two ago. Such an impressive provider. So she's the coordinator for the ETSU IRB.
Thank you, Teresa.
And Morgan Tipton also said, very impressive. Morgan's a care coordinator with ETSU Health OB and Pediatrics clinics. And I know she has been viewing from the clinic with the Baby Steps team, Michelle Johnson and Dr. Pure. So I have a question because I know this topic is one that Dr. Pure has discussed with the Baby Steps team. So this is in our pediatric clinic.
And actually, Dr. Pure was about to ask a question.
Oh, fantastic. Dr. Pure, I'll let you ask your
I'm like,
question.
look at the perfect timing. So I'm in clinic, so I'm masked and I'm trying to show my face slightly. So I'm with Morgan, so only Morgan's showing up, but I'm Morgan right now. We were sitting here watching together. So I don't know if this is the same question that you were going to bring up or not, Dr. Scazzino, but so in Baby Steps, so we know that relapse, we know that this is, or return to use. We know that this is going to happen because it is a chronic condition. And we have been working on bringing that more into our conversations with our moms who are in recovery. Since we are pediatricians and seeing the children, would you speak to what that means as far as a child safety issue, but also who are living with families that we know that this is a chronic condition? And would you just speak to what that looks like? An excellent talk, Dr. Troxler. We really enjoyed it.
Thank you very much. That is a challenge when you're talking about return to use and yet there are kids in the picture. Very challenging. So one of the things I always ask when we're talking about a return to use and mom is bouncing a baby on her knee or there's a toddler running around in the background is, where are you? What was the circumstance of the use? And most of the time, the answer I get back is, I was not with my kids when this happened. Which hopefully is exactly what they're telling me. So I go with the benefit of what they're telling me is factual, because I also know that they don't want to harm their children. They do not want their children in harm's way. So it's like, where was the kid? I was like, well, my mother had the baby, or, someone was babysitting for me, or it was, so there is a setting in which the child was not present. One of my patients that I had who had returned to use, and she went back home afterwards. I'm like, and so when you went back home, were you still altered? So even though the use happened outside of the home, what was it like when you went back home? And in that particular instance, she lives with her parents, so her parents were watching the child. Because when she went back home, it wasn't quite like finished and over with the experience. But her parents were watching the baby while she was out. So not until she had cleared the experience did she engage with her child. So assessing for what is going on with your return to use and the people that you're responsible for, what's happening in there. So I ask those questions. And if I start getting concerns about, there's a lot of return to use, like things don't look good, I'm concerned about you taking care of yourself and this child, we call CPS. We do. And quite honestly, we tell them. So we're going to, because it's out of concern. That and often, as unfortunate as what I'm about to say is, it can be something of a motivator. It's a little bit stronger, stricter. Like I have these outside people who are requiring this of me. So in some ways, like I'm concerned about you and I'm concerned about what we're doing, and it's dangerous and it's not safe. And even though I want to be supportive of you and I want to guide you back toward recovery, I can't ignore the fact that you're jeopardizing the health and well-being of someone else. I even got to use the 1-800 human trafficking line the other day. That was exciting. And there is, maybe you guys remember the name of this, but drug endangered children. Is that one you're familiar with? Where it's actually an agency within the Tennessee Bureau, where when I called and gave my report, and because there's a 1-year-old involved in the, like, I'm concerned this woman is being trafficked. There's a baby as well. And so I have no idea what happened at all, but I gave the information, and it's like, we'll figure out what needs to happen depending whether that we think this is human trafficking or not. And then later on, I realized there's also that section of like, because there's a kid around and I have no idea what this kid is being exposed to. Because we had actually tried CPS on that particular patient before and they couldn't find her. So they closed the case. Yeah. But I inquire, and if I feel as though the child is endangered, I let the family know that I'm concerned, and that's going to happen.
I think that's very helpful. And Dr. Skatsina and I participated in an AAP echo on opioid use disorder and taking care of the children involved. And that's what we're aiming to kind of, we've had, this happen a few times with some of our families and how best to address that. And so viewing CPS as more of a support system, an extra accountability and extra support system rather than it being punitive. And so changing the relationship. And I've spoken with some providers who will even call CPS with the family in the room. Like, I'm going to have to report this and call. That way, we have not yet done that personally, where we've done it with the family in the room. But they have found that can be helpful because they know exactly what's being said and they don't feel like they're being talked about. And I think the challenging piece is we know return to use happens. And so let's say the child's in a safe place, but it's a hard thing to decide at what point does this meet requirements for reporting. Let's say they weren't with their child when they returned to use, but it's such a hard thing knowing that's going to happen. So I would like to see us build more relationships with CPS, so it is more of a collaborative effort to really put that safety net around families and move them forward, helping them rather than it being punitive.
I agree, 100%. Having a better working relationship with CPS is, I think, something we all would like to have. But there's also, and I would be remiss if I didn't bring this up, because we focus a lot on the illicit substances, and I think we miss the legal ones because we aren't really screening all that well for what's happening with alcohol in the home and how much is being used. Because whether it's methamphetamine, heroin, or alcohol, if you're using it to the point of altered state, you're not safe, even though you can go to the liquor store and buy one. I feel like the alcohol one is one that's just we're not addressing as well as we should either. And when you pull back and look at morbidity and mortality, alcohol is associated with poor outcomes, a larger number of poor outcomes than opioids. It's just opioids kill people faster. So, because we aren't calling CPS because we aren't asking the questions about, oh, how much alcohol did you have to drink Saturday night, mama? Or even benzo use. That's another one. A lot of our mamas are prescribed benzos too. So It's hard. It's hard to know. I feel like there's a line here. Am I on the side of it that I want to be on? Sometimes the line moves and you fall down on your face. It's not what any of us want to be, and we don't want our families to find themselves in that situation either. So, excellent point and question. Thank you.
Any other questions? I know we've lost some folks that probably had a 1 o'clock commitment, but if you're willing to answer another question, Dr. Troxler, we'll see if anybody has any. So Dr. Pure asked one of the questions that that I had related to when kids are involved or when it is a kid, how that changes the conversation that you have. My other question, and this came up during that AAP Project Echo that Diana mentioned, you know, time is always our enemy, right, in clinic, especially for primary care providers who have like 10 or 15 minutes to see patients. And so I was wondering, and we asked this in the Echo too, like, are there validated or recommended ways to efficiently identify people who are at risk for return to use that you need to devote more time and resources to? And so I'm thinking about things like screeners or screening questions. And, you know, I know one of the responses we got in the Echo is that this is sort of an expected thing, just like you said, return to use. It's not the rare bird. And that another approach you can take is just provide, you know, support for not returning to use to everyone. But again, just the thought that enemy is time is our enemy, and or at least a barrier. And how do you identify those folks that really do need help?
I don't know that there's a validated screener specifically for risk for return to use. There are so many screeners out there, though. I actually wouldn't be surprised if there was one, and I just don't know about it. But one of the things that we use, and it's a little lengthy, so it's not like quick, but it does give you some insight. It's the World Health Institute Quality of Life questionnaire. And it's something that we use because really when we start talking about outcomes for our patients, it's not how many negative urine drug screens have you had. That's really not the outcome that I want to see. Be like, that's great, whatever. Are you getting what you want out of life? Are you going back to school because that's what you want to do? Are you getting visitation with your kids because you want to and you've been working really hard to get that? Are you repairing relationships? Or have you realized some relationships just need to go away and you're making new positive ones? Like, what is happening in your life? What is the quality of your life? So that one asks on several different domains, areas in which you are satisfied with your life experience, which you can because we repeat them. And you can sort of see when they first come in, quality of life scores tend to be lower. And then after some time in stabilization, they start to improve. We've only started using that screener, so it will be interesting to see if we start to see anybody having a decline. And it's like, oh, that is one that, you know, we should have seen coming, or now we're going to know that's coming. Another, I haven't gotten my hands on this study, but I feel like Morgan just asked, what is the screener called again? It's the WHO Quality of Life. I may have said World Health Institute. World Health Organization Quality of Life, WHO QOL.
Okay.
But there's that one. And then just with ACEs, there is a correlation to number of ACEs and the likelihood of return to use. So someone that you're seeing, this isn't like proof positive, but someone who has an ACEs score of 1 compared to someone who has an ACEs score of 7, the likelihood of return to use for the one who has an ACEs score of 7, much, much, much more likely. And they're going to need a lot more support and a lot more help, kind of navigating through what those 7 adverse experiences produced in their developing brains. So that's kind of a quick one. And are you guys using the ACEs, the pediatric ACEs, where there's 2 sections to it, or which one do you guys use?
Morgan is using, right now we're just screening the, for the parent or caregivers ACEs, and it's adopted from the ACE-Q from the Center for Youth Wellness, Nadine Harris.
Okay.
And it is brief. We do so much screening in our clinic. We opted for just the brief portion, and right now just parents and caregivers.
Okay. Yeah, because I like their teen screener a lot. And just when someone is experiencing those things, because it's talking about now, and when you're having some of those experiences, then that can also like, well, that's some crappy stuff you're experiencing. When was the last time?
What is that one you said that you like?
The teen.
For teenagers, or did you say team? T-A-T-E-A-M. Teenagers. Yeah. Yeah, they have them for different age groups. So
Yeah, the self-reporting teenager.
Yeah. But we're just using the short kind of 10-item ACEs. It's not
the basic ACEs.
testing for the basic ACEs, not the other ACEs, not resilience. Those kind of are more through conversation, but it's not part of a paper screener.
Yeah.
The other question we added was to what extent are these past experiences affecting you now to help guide the conversation. So we added that.
Cool.
Well, thank you so much. And Morgan said she found the screener that you suggested online. So thank you so much,
You're welcome,
Joyce. And I think we just have the Baby Steps team and Dr. Kinzer and Katie and you and I left on the call, but I appreciate you staying after to answer some questions.
Yes, definitely. Well, thank you for offering this opportunity to come and speak. I enjoyed it.
Absolutely.
Thank
all right.
Morgan.
Bye, everybody.
Bye. It was good to see you all.
You too.
Bye.